Hello, welcome to this Ask the Expert session. My name is Dr. John Fahrenholz. I'm an allergist immunologist at Vanderbilt University Medical Center in Nashville, Tennessee. In a recent program titled Managing Non-Advanced Systemic Mastocytosis, it was an ACAI expert roundtable session. We offered learners the opportunity to ask our experts some clinical questions that came up while they were reviewing the activity. Today, I'm going to be providing some of the answers to those questions that were submitted. So a patient case was shared. I saw a patient with repeated hospitalizations after insect stings, including one ICU admission. The baseline tryptase was 19, being mildly elevated. How common is systemic mastocytosis when a patient has a normal tryptase? It's uncommon, but definitely possible. And in this situation, with ICU admission and multiple hospitalizations to stinging insect, the risk is significant. And in this case, would it be worth to pursue a bone marrow biopsy? The answer to that is yes. So the other test that we would perform would be a peripheral blood KIT mutation, most likely. However, 5% of the time, a KIT mutation will be negative even in systemic mastocytosis. So this patient should ultimately go to a bone marrow biopsy no matter what, given the increased risk of mastocytosis with the history alone. In this case, even if the serum tryptase was lower, even upper limit of normal, say around 10, so completely in the normal range, this would be somebody who would warrant a bone marrow biopsy. Another question came up explaining in detail how to differentiate between systemic mastocytosis, hereditary alpha tryptosemia, and mast cell activation syndrome. For me, the most straightforward way to approach this is thinking about first systemic mastocytosis. So systemic mastocytosis being a clonal neoplastic and a chronic cancer of mast cells in the indolent systemic form. Of course, in the aggressive form, it's an aggressive cancer, but your first job is to look for systemic mastocytosis, the clonal disorder. And people with systemic mastocytosis have a high risk of having severe anaphylaxis, particularly stinging insect anaphylaxis that we addressed in the prior question. So you would look for serum tryptase, you would look for peripheral blood KIT mutation in that type of patient scenario. Depending on your findings and your risk of, your suspicion risk, then you would also consider going to a bone marrow biopsy. Hereditary alpha tryptosemia is a disorder we're still figuring out, if you will. We do know it can coexist with systemic mastocytosis, so it's not something you can completely differentiate from systemic mastocytosis because it can occur at the same time. So people can have both disorders. So hereditary alpha tryptosemia is tested with a genetic test that looks for extra copies of the tryptase gene. Next is mast cell activation syndrome, and this is a non-clonal disorder. So mast cell number is normal, serum tryptase at baseline will be normal, and patients are diagnosed based on having systemic mast cell mediator symptoms, notably skin symptoms with urticaria and or flush with pruritus, and then a second system involved with respiratory, gastrointestinal, or cardiovascular symptom involvement. So it does not have to be full-blown severe anaphylaxis, but anaphylaxis spectrum symptoms that are recurrent. Now, notably, these symptoms can happen in all three conditions, and they can be combined. So in detail, how to differentiate you have to focus first on, is there a clonal mast cell neoplasm that's baseline tryptase, that's peripheral blood KIT mutation, and if a significant suspicion of bone marrow biopsy. Once systemic mastocytosis has been ruled out, then you're thinking about, is there hereditary alpha-tryptosemia? Now, you may have sent the gene test more simultaneously, which we'll often do in the setting of a mild increased serum tryptase at the time of doing the KIT D816V mutation analysis. So if we step back to mast cell activation syndrome, generally speaking, there's no systemic mastocytosis. Probably hereditary alpha-tryptosemia has been ruled out. And that's the clinical spectrum of those recurrent mast cell mediator symptoms that we've discussed. And you would need for confirmation to find evidence of increased mast cell mediators during a symptom flare. Ideally, that's tryptase at baseline and during acute reaction. Other markers that are helpful can be urinary methylhistamine measurements, prostaglandin D2 metabolite measurements, and more recently, based on data out of the Mayo Clinic, leukotriene elevations have been noted to be perhaps the most common increase that will be seen in patients who have had a definite diagnosis with confirmed mast cell tryptase elevation during episodes. So a long answer for a relatively complicated overlapping condition. So that's a lot of detail. I hope that's been somewhat helpful, but you have to develop, I think, a mental picture of going through the various steps due to the fact that there can be multiple diagnoses at the same time. I think the key point is realizing a patient with hereditary alpha-tryptosemia is someone who still might have systemic mastocytosis. I think earlier on we thought hereditary alpha-tryptosemia and finding that extra copy of the tryptase gene essentially ruled out systemic mastocytosis if the tryptase was only mildly elevated. However, that's not true. Approximately 18% of patients with systemic mastocytosis will have alpha-tryptosemia as well. So with avapritinib available for use in patients with indolent systemic mastocytosis, when do you add it to the therapeutic regimen? So basically, if you have a patient with systemic mastocytosis who remains symptomatic on the treatments we will typically prescribe, so what we're using is H1 and H2 antagonists. Leukotriene modifiers are helpful for some patients. GI symptoms are often improved with oral cromolyn and gastrocrom. And then in patients who have a history of severe recurrent anaphylaxis, whether that's triggered by antigen or in particular if it's spontaneous or idiopathic, we add omalizumab to their treatment program. These treatments often help with recurrent anaphylactic episodes and somewhat for GI and somewhat for skin symptoms. However, urticaria pigmentosa is completely refractory to treatment with antihistamines in general, topical steroids, etc. And many of the neurocognitive symptoms, particularly fatigue, just feeling ill, brain fog, and then also gastrointestinal symptoms with abdominal cramping, loose stools, and diarrhea are often more persistent, smoldering, chronic issues. And in somebody who's symptomatic, we would add avapritinib. So any patient who has significant ongoing symptoms, you would want to consider avapritinib treatment. That's been shown to improve the neurocognitive symptoms, the gastrointestinal symptoms, and the cutaneous symptoms of mastocytosis. So what do we need to consider to advance our knowledge with rare allergic reactions? Well, I suppose we all need to stay up with the literature and be looking at case reports, et cetera, our CME and so forth. But in terms of specifically trying to dig into rare allergic reactions, there are some helpful publications that discuss hidden allergens, whether that's excipients in medications or vaccines, that we can post for you here. Also would be some rare food allergens to think about. Alpha-gal is a common allergen in the Southeast, and with people traveling, of course, even if you're not in the Southeast, that's a trigger that you will likely come across no matter where you're practicing. And so becoming familiar with that allergen, which is in mammalian meat, will cause delayed anaphylactic reactions 3 to 6 hours after ingestion. And so that's something that is obviously different than what we see with our typical food protein allergens causing anaphylaxis. And otherwise, I always refer people to the practice parameters for anaphylaxis for just generally good overview and approach to patients with a history of severe allergic reactions. Another question is regarding patients with severe allergic reactions to medicines. So what do we need to consider in patients with these, I'm assuming, prior severe allergic reactions to medication? So that obviously would be avoid those that there have been severe reactions, but then what often comes up is, well, what is safe next? And perioperative management with which medications to choose. And then another segue would be, what about antibiotics? Are there any particular antibiotics that should be avoided or not? In terms of perioperative management, there are publications, and the Mastocytosis Society has a list in a document that reviews those in terms of perioperative management. Generally, patients with systemic mastocytosis are at increased risk for adverse reactions to narcotic pain medications across the board. They're not contraindicated, as some people will tolerate codeine, hydrocodone derivatives. Other patients have marked cutaneous symptoms associated, and some people could have more systemic reactions. Fentanyl is the notable exception regarding narcotic pain medications. It does not cause mast cell activation through the relatively newly described MRGPRX2 receptor on mast cells. So fentanyl is a go-to when there's severe pain, perioperative, and a narcotic is needed. The antibiotic class that's more likely to cause cutaneous symptoms in patients with mastocytosis would be the quinolones, such as ciprofloxacin, levofloxacin, because they do trigger mast cells through that same MRGPRX2 receptor. And so that's a consideration, but again, not a contraindication to quinolones, just a basic caution. Radiocontrast is the other class of general medicines that can also more likely trigger patients with mastocytosis based on that same mechanism. However, you can pre-medicate patients per standard protocols that include antihistamines, and in some cases, systemic steroids have been used. Thank you for your time today. Hope you found this information helpful. And please subscribe to Exchange CME's YouTube channel and check back regularly for updates on systemic mastocytosis.